Welcome to our guide on managing Wolfram Syndrome. This is really designed for you, the endocrinologist, because as you know, you're the one serving as the central coordinator for these complex patients, often for their entire lives. Okay, so here's our game plan. We'll start by talking about the management challenge itself. Then we'll dive into the core endocrine issues you're dealing with day to day. From there, we'll broaden out to the other systems that need your oversight. We'll also look at some really exciting emerging therapies and then wrap it all up by hammering home why that coordinated, multidisciplinary approach is just so critical. All right, first up, the management challenge. We're moving past the initial diagnosis here. We're focusing on what this disease truly demands, which is proactive, lifelong management of something that is constantly changing. And here's the crucial point. While diabetes mellitus is often how these patients first land in your clinic, that's really just the first chapter of a very long book. The real clinical challenge is the relentless, multi-organ progression of the disease. Your role has to expand way beyond just managing blood sugar. You become the coordinator for this whole cascade of issues that are going to unfold over decades. Okay, so let's start where you live, right? In your primary domain, the endocrine system. And here, we're really facing two distinct, but as you'll see, intertwined challenges. Now, this is where things get really interesting, the huge distinction in the diabetic phenotype. Unlike classic type 1, the diabetes in Wolfram syndrome is often autoantibody negative. But even more importantly, there's this period of persistent residual insulin secretion. Now, this initial honeymoon phase might make glycemic control seem a bit easier at first, but it also gives us a really unique therapeutic window. And this is exactly why that distinction matters so much. Because some of that beta cell function is still there, therapies beyond insulin are a real possibility. We're talking about agents like GLP-1 receptor agonists. They aren't just for glucose control here, they might actually protect the remaining beta cells by cutting down on that endoplasmic reticulum stress that's driving the disease. I mean, look at that clinical note, a case report showing a 70% drop in insulin needs with exenatide. That is a massive signal that we could potentially change the whole trajectory of the diabetes. And then, of course, we have to manage the other diabetes, central diabetes insipidus, which, affects a huge portion of these patients. Management with DDAVP is the standard, but it requires really careful titration. The big challenge is that the polydipsia from poorly controlled diabetes mellitus can easily mask or get confused with the symptoms of DI. This makes it absolutely critical to tease the two apart and keep a close eye on those sodium levels. All right, so we've covered the endocrine core, but as the coordinating physician, your job goes way, way beyond that. Proactive surveillance of these other key systems is just essential if we want to preserve function and quality of life for these patients. So this table is basically your playbook. It lays out the essential surveillance schedule you've got to have in your mind. We're looking at annual neurology and urology checks to catch things like ataxia or bladder dysfunction before they become severe. And for the sensory systems, you see it's even more frequent, especially in kids. This isn't just some checklist, it's a proactive roadmap to try and mitigate the relentless progression of this disease. This brings us to the really exciting part, the future of treatment. For so long, our approach has been just managing symptoms as they come. Now let's look at the next frontier, the shift towards actual disease-modifying agents. And we're going to use the dantrolene sodium trial as our case study here. So you might be asking, why dantrolene? Well, preclinical work suggested it might directly target the core problem in Wolfram syndrome, that excessive cellular stress and programmed cell death, or apoptosis. So this trial out of Washington University was designed to see if this mechanism could actually hold promise in people. Right, but before we get ahead of ourselves, remember, this was a phase 1b trial. And what's the number one role of phase 1? Safety, safety, safety. So the primary goal was simple and absolutely critical. Is this drug safe and tolerable for patients with Wolfram syndrome? Before we can even dream about efficacy, we have to establish that safety profile in this very specific, very vulnerable population. But of course, while they were checking for safety, the investigators were also on the hunt for any early signs that this thing might actually work. The secondary objectives were so cleverly designed to look for any hint of a positive effect across the three core areas that this disease just devastates. Endocrine function by looking at C-peptide, vision using log-MAR scores, and neurological status with the Wolfram Unified Rating Scale. And for us clinicians, the nitty-gritty details matter, right? This slide shows you exactly how they did it. A really careful, stepwise dose escalation over a 3-week period for both adults and kids. This kind of cautious approach is just fundamental to keeping patients safe while you're trying to get to a therapeutic dose. And this is so important. These are the safety guardrails they built right into the trial. These aren't just vague guidelines. They are specific, objective stopping criteria. Whether it's a significant drop in hand grip strength or a very clearly defined rise in liver enzymes, these criteria give you a clear, actionable plan to protect the patient. It's really a model for how to monitor safety in any future trial. Okay, so how do we pull all of these different pieces together in our daily practice? Well, it really comes down to the team. And you, the endocrinologist, are right at the center of it all. You're the quarterback of care. I mean, just look at the breadth of expertise that's required here. This table, which is adapted from the UK's National Care Protocol, it just perfectly reinforces the point. You've got your core medical specialists, ophtho, neuro, urology, but just as critical are all the allied health professionals, the nutritionist, the psychologist, the physiotherapist, the social worker. They are all absolutely essential members of the team that you're going to need to assemble and lead. So if you take away just one thing from all this, let it be this. Your role with a Wolfram Syndrome patient goes so far beyond just managing hormones. You are their medical home. You are the chief strategist, always trying to anticipate the next stage of the disease and pulling all these different inputs together into a single coherent plan to give them the best long-term outcome and quality of life possible. And that really leaves us with this final, kind of provocative thought. With therapies like dantrolene showing us a path to targeting the root cause of cell death, are we on the cusp of a new era? An era where we move beyond just managing the consequences and actually start to modify the course of this devastating disease? That's the hope that drives the research. And really, it's the hope we hold for our patients.